Well, welcome everybody. I'm so happy to have the opportunity to be here today. This is really special for me. So as you know, I've created the Focus Builder app, and I have a partner in that with Jason Whitaker. And we are just dedicated to bring to you a means to do eye movement training in your office, but also for patients to have it at home at a very affordable rate. And the cool thing with iPads is you can kind of take them just about anywhere. We are constantly working on this app. We've been doing that since 2012. And we are, every single month, we're adding something slightly new to the app. And we're just dedicated to make it better and to keep it affordable for everybody. So eye movement training, a cool thing about the eyes, as you've heard this morning, is it's absolutely essential to human function, especially in a multimodal system. I think that the key here in all that we learned is the multimodal component. So eye movements are incredibly powerful, but they're even more powerful when combined with other modalities. So in this presentation, I'm going to really attempt to give you the why we use eye movement training, give you a little bit of some of the current research. Now, we've seen it quite a bit already this morning. Also an overview of the basic concepts, how to fix a broken system, some of the basic neuroanatomy of eye movements. And also, I'd like to introduce our very latest addition in the Focus Builder app, which is, I think, a very promising eye movement strategy. So if you're a very seasoned doctor and you know a lot about eye movement strategies, eye movement training, and you feel like a lot of these foundational concepts that I'm going to present are things that you already know, I would encourage you, at the very least, to stick to the end, because this new eye movement therapy application that I'd like to introduce today, I think is very profound, and it's available in the Focus Builder app. So how impactful is the visual system on the brain? Well, to answer that question, I think it's really important to consider two other questions. One is, where are we in our environment, and where is our environment compared to where we are? That is something that our brain has to answer always. And in order to answer that question, or those two questions, we rely on the visual system, we rely on the auditory system, we rely on the somatosensory system, we rely on the vestibular system. We rely on integration of all those systems, and they have to be coherent. They have to tell the same story or send us a message that fits. But what happens if it doesn't? What if the right posterior canal is telling the brain that we are falling back into the right, but the visual system says, absolutely not. We're not. I can tell we're perfectly still. So the brain has to make a decision at this point. It has to suppress one of the two systems. When you have an imbalance like that, it creates compensations. And the very first place that you're going to get these compensations is in your muscular system. Like the talk that Annette just presented here, you see that there's effects on posture. There's effects on physiology. And so vision is also important because it's closely integrated with all other senses. We perceive up to 80% of all impressions by means of our sight. The visual system is the only system that can actually tap into every part of the brain. How incredible is that? So when you see a gorgeous dish like that, it's called poutine, where I'm from in Montreal. It's very well known. It's a staple dish. You have fries and gravy and cheese that's melted in there. It's absolutely amazing. I don't understand why it's not more common here, but I understand why it's not popular in this setting here, but we're a little bit more health conscious. But when you see a poutine, it just looks amazingly delicious. Your sense of smell kicks in, your taste buds kick in, and you get hungry, especially at this time of day. I think we're all pretty much ready for lunch. But all because of a visual input. That's how integrated this system is. What if we see something a little scarier, like a big, scary spider? Well, then we get goosebumps, and we get an emotional response of fear. So again, vision is closely integrated to so many functions in the human body. Vision will help us process, understand, and take action in our environments. Eye movement disorders are also often the initial manifestation of a central nervous system problem. Vision can affect posture, as we've spent the last hour analyzing. It can affect the stability of your spine and its mobility. It can affect integration into the brain, and all the way down to end organs. Let's take a look at what the research shows. So when I'm here talking about vision, let's kind of take a quick look at what some of the work that other people have done on this here. This particular study here is looking at the oculomotor task and its effect on postural control. And they had a group here that was divided in two. You had a normal 30 non-dyslexic kids and 30 dyslexic kids. They found that there were some differences between the two groups. The dyslexic children showed significantly poor near fusional vergence ranges. Also during the postural task, the quality of fixation and anti-saccade performance in dyslexic children were significantly worse. Concerning postural quality, dyslexic children are much more unstable. But the result of this article is that executing saccades increases postural stability. And it found that in both groups of children. This other study here, also on children, this is one we've seen actually earlier today, but saccades improve postural control. And so they reduce postural sway. In this particular study, it's looking at an elderly group, and active ocular vergence improved postural control in elderly. Postural stability significantly worsens when fixating on a target that is far, but it improves when fixating on a target that is near. Smooth pursuit eye movement training promotes recovery from auditory and visual neglect. Eye movement training and suggested gaze strategies in tunnel vision. So in this particular article, exploratory saccade training was beneficial for retinitis pigmentosa patients and resulted in shorter fixation durations after training. It also improved their walking speed. Eye movement training results in changes in QEEG and an NIH stroke scale. This particular study was actually performed by Dr. Carrick. And what it showed is that they had two groups of acute stroke patients. And in both groups, they had the conventional care applied. But in one group, they also added eye movement training. And what they found is that there was a significant difference in the outcome of the group that did eye movement training along with their conventional approach versus the ones that did not. And lastly, smooth pursuit eye movement training improves recovery from functional neglect in individual with post-acute stroke. So there's plenty of evidence there showing that obviously there's a lot to eye movements. A lot of work's already been done, and it's something that we just must integrate clinically because the effects are so far-reaching. Let's take a look at some foundational key concepts that we need to know if we are to consider using eye movement training in our office. Well, for one, we can use eye movements as an assessment tool. You'll see on the right-hand column, when you use eye movements as an assessment tool, you want to compare a reflex to a volitional movement. That's really important because if you find that one's impaired, you may be able to use the other to help improve it. You also want to compare a horizontal to a vertical movement. We always compare right to left, up to down, but horizontal to vertical. As a therapeutic tool, eye movement training, as I've been saying, is especially powerful in a multimodal approach. If anything, try to remember that. It's the multimodal integration of multiple therapies that gives it even more power and effectiveness clinically. It can be used also to repair a broken system. So in other words, if you've got an eye movement strategy that's impaired, you can use potentially a different eye strategy to help restore the one that's impaired. We'll go through those. But basically, a rule of thumb is to use something that works to repair or restore something that's broken. That's a great one to remember as well. It can be used to specifically activate very specific regions of the brain. And so we'll go through that in depth as well. If everything's working, can we use eye movement training to specifically activate areas of the brain that we want to activate? And the answer is yes. You know, I think a lot of us in here are already doing that. But we must also understand the 6 muscles that move the eye. And I'm not going to spend much time on this, but we basically have 2 elevating muscles. You've got the superior rectus and the inferior oblique. So don't get confused by the name. It's an inferior named muscle, but it moves the eye up. So the mechanical advantage to elevate the eye for the superior rectus is when the eye is abducted. So when the eye is in lateral gaze, the superior rectus has the mechanical advantage to elevate the eye, and the inferior oblique is the exact opposite. When the eye is deviated nasally, it'll elevate the eye. So lateral rectus muscle and medial rectus. So the medial rectus, I just saw a sign from you. I just got it. I had a different picture up here this morning, and I thought, you know what, I kind of like this one, and I switched it. Well, it's wrong. The medial rectus and the lateral rectus should be reversed. So anyway, let's just not look at the picture. The lateral rectus, just look at me instead of looking at the slide here. Well, yes, so where it says adduction and medial rectus, you can look at it and say, yeah, so the superior rectus muscle and the inferior oblique muscle should be switched. Same with the inferior rectus. Either way, I'm going to get off that slide because that one's wrong. Okay, so don't look at it. So the medial rectus, it's medial. It pulls the eyes medially. We know that. It's adducting the eye. The lateral rectus abducts the eye. The superior rectus, let's say I'm talking about my right eye here. The superior rectus will elevate the eye when my eye is abducted. That's the mechanical advantage for it. But when you elevate the eyes in the center, really you have 2 muscles elevating the eyes, the inferior oblique and the superior rectus muscle. They both elevate the eye. When you depress the eye, you have the inferior rectus and you have the superior oblique muscle that bring the eyes down. Okay? There's a lot more to the eye movements and you know what they do. For today's purposes, let's just stick to that. Okay? 6 muscles on each side. We also have 6 eye movement systems. Okay, 3 that hold the image steady on the retina, and 3 that direct the fovea to an image. We have to know these. This is what we work with. Okay, this is what we assess. This is what we work with. So if we look at the 3 that hold the image steady on the retina, first we have fixation. And fixation is holding the image of a stationary object on the fovea when the head is still. That's fixation. The VOR, well, the only difference is you have a brief head movement. So you hold the image steady on the retina during brief head movement. So this is an example of a VOR activation. So the head moves as I maintain fixation on a still target. And the latency of the VOR is about 15 seconds. Okay, beyond that, you're going to start engaging an optokinetic response. The optokinetic system holds the image steady on the retina during sustained head movement. And this is what we get if you're in a car and you're looking out the window and the car is moving forward and you're seeing houses or maybe other cars moving down that way. That's the optokinetic system. So basically it gives you a sense of movement, but through visual perception. So the other systems direct the fovea to an image. So we've got saccades, pursuits, and vergence movements. Saccades bring the image of an object rapidly on the fovea. So an example of a saccade is if I'm looking here on my thumb on the left, and then I move my eyes to my right thumb. That's a rapid movement. It's a saccade. A slower movement is a pursuit. And we're going to dive a little bit deeper in just a second. as to when you would use which one to have which effect. But pursuit movements, you basically hold the image steady on this moving target. And vergence movement is basically holding the image steady on a moving target, but your eyes move in opposite directions. So we have convergence and divergence. We have to assess all of those to get really a full picture of what's happening with someone's visual system and their eye movements. And then we have advanced eye movement strategies, which affect the dorsolateral prefrontal cortex. These are more executive regions. So you have your anti-saccades, you have your memory-guided saccades, and then the new one that I want to introduce a little bit later is saccades with manual tasks and interactive metronome, all wrapped into one. It's pretty cool. Anti-saccades are so beneficial for multiple reasons. I use those a lot as well if I want to have an effect on the dorsolateral prefrontal cortex. But basically what anti-saccades are is you have to suppress a reflexive saccade to a target and then invert the visual vector. So if I'm the patient and the doctor puts their thumb up, my instruction to the patient is don't look at my thumb when I bring it up. Look at the opposite mirror location of where the thumb would be. So thumb comes up and you've got to look right here instead of looking at the thumb. Okay, so you could see it here. Let me play the video. I think it paused. 1 second. Okay. So basically, you see a target appear on one side, and you have to look at the exact opposite side and come back to center and repeat that. It's considered normal to miss 1 out of 4, but ideally, you don't want to miss any. You know, you want a really highly functioning system. Now, the memory-guided saccades, that's pretty simple. Basically, we have that function in the Focus Builder app, but you know, you can even do it at bedside. You can do random saccades, and the patient would have to remember, let's say, the sequence of multiple saccades, 1, 2, 3, and you could have them close their eyes and repeat that sequence, or even do it with eyes open. So the patient has to remember exactly where their eyes moved and repeat the sequence. We've got a touch feature on that particular exercise on the Focus Builder app so that the patient can not only move their eyes to the way they remembered that saccade to be, but they also have to touch a tile. And if it's correct, it'll light up in green. If it's wrong, it'll light up in red. And I often will have them go back to center. So I'll put a fixation dot in the center of the screen, and I'll have them look at all the saccades that appear. Let's say we do 3 or 4 of them. And then they have to repeat the sequence. But I like to ask them to move their eyes first, and not just touch where they remembered the targets appearing. But they would move their eyes to where the first one appeared, and you would touch it there, where the second one appeared, and touch. Third one appear, return to center, and fourth. What we've done is we've added multiple levels of complexity to this exercises. You can actually select to do it in order or in reverse order or both. We can add a mirror effect where the targets will only appear on the right side, and you have to first remember where they appeared and select the appropriate tiles, but then mirror that to the other side of the screen and do the exact same thing, but in a mirrored effect. And then you can also mirror quadrants. So then you have to flip what you remembered, you know, upper left quadrant to the upper right quadrant to the bottom quadrant, and kind of keep flipping that around. And you could do it in reverse order and all those mirrored locations. So it really gets the patient to work, to really work hard, work that dorsolateral prefrontal region. So what if we've got impairments? What if some of our eye movements are not working as well as they should? Let's start with gaze fixation. So I'm sure that you must have heard from colleagues here and there, you know, people doing yes, yes, and no strategies. Well, if your gaze fixation is impaired, in other words, if you're staring at an object, let's say the examiner's thumb or pen, and you're not able to maintain your eyes fixed on that target, if your eyes deviate off target, if you get these intrusions that push your eyes off target, then gaze fixation exercises are in order. We use the VOR. Most commonly, we use the VOR to repair this problem. So an example, and I'm not going to get into all the possible ways that we could use it because that would probably take up the rest of the time here. But just to keep it simple, the VOR you can use in a horizontal plane or in the vertical plane. I'm sure you can think of scenarios where you might need to do it in the plane of a canal. That's very possible as well. But the key here is to not move the head very fast, because if you move too quickly, then you create too much of, well, you activate the system too much. So you want to, in a therapeutic perspective, to do it very slowly and start with a small amplitude. And over time, you can stretch that amplitude out. The right eye system, and they're here, they've done a spectacular job at making it so easy to assess all these things. What I love about their system, and they have a booth here, is that when you run these tests, I mean, you can get them done in minutes, which is awesome for pre and post testing. But they have the fixation test there, so you can see exactly what the eyes are doing and the whole map of its motion. But also, when you do eye tracking on it, you can also see if there's if the eyes are converging too much or diverging. And you can actually replay, do a live play of exactly what the eyes did when looking to the right versus left. And you may see a convergent spasm only to the left, but not to the right. You know, so they make it so easy. They've got it all recorded. What if the VOR system's impaired? Well, we need to test it first. And so how do we test the VOR? Well, there's a couple different things we could do. One is you can ask your patient very simply, when you're still, can you see clearly, you know, you can use an eye chart. Can you see this eye chart very clearly when you're still? And then you can have them walk towards it and ask them, does it get blurry as you walk? Can you see it just as clearly as how it was when you were still? And if the answer is no, then there's a strong chance that their VOR system is impaired. It may be functioning some, but it's not functioning normally and at its best. So that's a simple thing you could do. You can also do head impulse testing. So you would actually move the head briskly in the plane of the canal. And it doesn't have to be far. You know, you could do just a small movement. We have 3 canals on each side. We have a horizontal canal, the right horizontal canal. When you move your head to when you turn your head to the right, you activate the right horizontal canal and you inhibit the left. When you move your head back into the left, you activate the right, back into the right, you activate the right posterior canal, and you inhibit the left anterior canal. So those are the planes of the canals. We have 2 posterior, 2 anterior, 2 horizontal. And so when you do this impulse test, you have the patient look at your nose, and you move their head quickly to the left, and you're looking at their eyes. You want to make sure that they're able to maintain fixation on your nose. And if you see that their eyes are moving with the head and then coming back to your nose, that's called a catch-up saccade, okay? Essentially what you look for is, are the eyes deviating off my target in any direction? That's the first thing you want to ask yourself. But then which direction? Are they going with the head and then coming back, or are they going pass in the opposite direction of the head and then coming back, which would be a backup saccade? And the difference there is the difference between an overactive and an underactive canal. So with an underactive canal, the eyes will go with the head and then catch up. In an overactive canal, the eyes will go past the target and then back up to it. Okay? That's incredibly useful. We need to know that because our strategy would be very different for an overactive versus an underactive system. So the VOR is a reflex. If the reflex of the VOR is impaired, we could use a volitional eye strategy to help improve it. So with an underactive VOR, a strategy that works really well is a 2 times viewing saccade. So 2 times viewing is this. if my right horizontal canal is underactive, okay, so I turned my head to the right, I was looking at the target, my eyes went with my head and it came back to it. So if it's underactive, then I could do a strategy where I'm looking in the center between two targets, and at the same time that I bring my nose to my right thumb here, I'm going to bring my eyes to my left thumb. Okay, so that's 2 times viewing. So it goes like this. Okay, so you can start really small. So that's a 2 times viewing saccade. What if it's overactive? If it's overactive, then at time 0 is very effective. Time 0, again, let's say the right horizontal canal is overactive. So I turn my head to the right and my eyes deviate off target, past the target and come back to it. That's overactive. So a great correction for this would be a time 0 saccade. So basically I'm moving my head and my eyes laterally together. So from the center to the right for a right overactive canal. By the way, the amount of time it takes to create change in these is super fast. For most of these strategies, and again, I love the rod eye system. Actually, my partner Jason Whitaker and I work with them. We don't work for them. We don't get paid for the amount of time that we put in there. I love it because they're listening to what we need, and they're putting that into place really quickly, which is basically what we do with Focus Builder. We want to create this program for you guys. We make it really inexpensive, and we're constantly working on it, and we're listening to your ideas. A lot of what we have in there is not our ideas. It's basically suggestions from you guys. But I love it because you can test so fast. Actually, you can, if there's only one function that you want to test, you can do it in less than a minute. It's so fast. So you do your test, you do your therapeutic approach, and you retest right away, and it should be different. It doesn't take long. It may not be perfect, but you want to see a positive trend of change. So what if the optokinetic system is impaired? Well, we want to test it. There's different options on how to test it. You can use an optokinetic drum. You can use an OPK tape. You can use an iPad. You know, we have this on our app. There's another OPK app out there as well. And you can use VNG. I mean, if you have a VNG device, great. You know, you can test it and record it. Hopefully, pretty soon, the right eye system will have the optokinetic in there too. But how do we repair it? Well, one effective strategy could be to use the VOR system. So I'm sure you're noticing a trend here. We use the VOR a lot. In all strategies, you always want to think, what am I going to do with the head? What am I going to do with the eyes? It's always a head and eye combination. And sometimes, you know, it'll just be an eye movements and head still. But regardless, you need to decide, what do I need to do with the head? What do I need to do with the eyes to create a change? So to repair an optokinetic system, we could use a VOR stimulation or a yes, yes, no, no type of exercise. The most common, you could say, deficit with optokinetic testing is going to be on the vertical. I mean, it can happen to the right, to the left, up or down, could be just one of those directions. But overall, in general, especially when looking at we'll say, a healthy population, maybe your lower back patients or the patients that you see in your office that are not seeing you for functional neurology, a lot of them have impaired vertical responses. And so when you test the optokinetic system, you look at the eyes. The eyes should be moving. And this is before giving any instructions. You just put that system in front of them, put the optokinetic stimulation to the right, and then do it to the left, do it up, do it down, compare all of those. But you don't tell them what to do. Because if you tell them what to do, then they're going to engage their cortex to perform. We're doing stare OPK. In other words, look at the screen, that's it. Just look at the screen. That's all you tell them. And the eyes should be moving. There's a slow phase and there's a fast phase. But just look and see if they're moving. That's it. Just look and see if they're moving. Are they moving when we go to the right? Are they moving when we go to the left? Are they moving when we go up? Are they moving when we go down? And is the amplitude of the movement different to the right than to the left, up and down, or vertical to horizontal? And then, if you want to look a little bit more specifically, you can assess the slow phase and the fast phase. But in general, just look for movement, and you'll see, is it impaired when we go up? Is it impaired when we go down? Well, if it's impaired on the vertical, where a vertical VOR strategy where you're doing, you maintain fixation and you move your head on the yes plane, could be beneficial. But you want to retest pretty much right away and see, okay, I did a number of these here, and you retest your optokinetic and see if you're getting a response. And you may have to do something different. I mean, it could end up being saccade exercises, or pursuit exercise. It could end up being something different. And that's the greatest thing about what we do is it's not concrete. We always have to determine exactly how we want to adjust our approach based on the patient presentation. Well, I'm doing terrible on time. Okay. So there's two different kinds of optokinetic responses, and we use them for different purposes. So I just got these pictures this morning. I realized last night really late, and I live in Georgia, so I realized really late that there were some errors in the one I had. And so I have a graphic designer that does this kind of stuff, so and it's 3 hours different, so it's like the middle of the night for her. Like, I really need these changed. Can you fix those for tomorrow? And at 3 this morning, my phone dinged, and I checked, and it was like, oh, they're there, great. I've got a lot more of these, by the way, coming, so I better get moving. Stereo PK, local PK. The difference is stereo PK is that reflex that we talked about, where there's no instructions to the patient. And it activates the pons and the mesencephalon on the horizontal plane. On the vertical plane, it's mesencephalon only, okay? The local PK, you could see that the cortex are highlighted. If in this particular case, it's going to the right, so if you go to the right and the instruction to the patient is look at every yellow monster on there. So every fourth is the same. Look at every yellow character on there. As the actual movement is going to the right of the patient, they're pursuing the target to the right and they're saccading to the left, and they're doing this over and over. So this is basically a right brain stimulation. But because it's on a horizontal plane and because the abducens nucleus is in the pons, then you're also activating the pons. So it's right brain, left cerebellum, pons. I'm sorry, I won't take any questions until the end because of time. I have too much to get through. So what if saccades are impaired? Well, again, we test them. We can do it at bedside. We can test them horizontally, vertically. What's the right compared to the left? And this is useful because when you compare right to left, you're comparing right brain to left brain, right? So you saccade to the left, that's the right brain. You saccade to the right, that's the left frontal lobe, to be more specific. But you can use diagnostic tools like VNG, eye movement tracking devices like the right eye, or saccadometry. But the right eye system, they're adding so much more. So for those of you who are familiar with saccadometers, you won't really need them that much longer. Pretty soon, right eye will do everything that they can do, but on the vertical and the horizontal as well. But let's just say for the purposes of this presentation, we're not going to get into how to make saccades faster, or how to improve their latency, which is the reaction time. Let's just talk about how to make them accurate for now. So you can have hypometric or hypermetric saccades. The strategy, again, is different depending on which one you got. And by the way, the accuracy of saccades is very much dependent on a healthy cerebellum. So the cerebellum is very integral here in accuracy. But if you perform a saccade from left to right and your eyes don't make it to the target in one shot, it makes a stop before it gets there, that's hypometric. Hyper, it goes beyond the target and comes back. An effective strategy is to do micro saccades, so small saccades, and that can help improve the accuracy of the longer one. You can also add a vestibular ocular reflex component to that. You can make your target stop each time long enough to do a no-no strategy. So if you're hypometric to the right, then you might want to do a left Halmaggi, so it's like a brisker left head motion and slow return. And you can do that at every target. Just make sure you focus on quality, not quantity here. You can do just one of those at each target, but do it really well and make sure the head really moves in plane. Now, also one other tidbit that I didn't mention earlier, if you're doing this on paper, you can even have a laser mounted on your head. You know, Motion Guidance is a great company that makes these awesome lasers, especially with some of the gaze stability exercise that you do on paper. You may have a target there in the center, you may have some on the sides or up and below. But what often happens is that patients don't move their head in plane. You know, they think that they're doing a no-no, but their head is kind of tilting. And that's why we often do it passively initially. But if you mount the laser onto the forehead and they can see where the laser goes, they can make sure to keep it in plane, and it makes a huge difference. Motion Guidance. Okay, so if it's hypermetric, so if you're doing saccades and you go past the target and come back, great strategy is a time zero microsaccades. A time zero is when you move your eyes and your head together. So if I'm looking here and I want to go over here, again, my head and my eyes move together to the next target. You can do that with, you know, multiple saccades, and you move your head and your eyes together. Times zero. What if pursuits are impaired? I think we already know. I don't need to play this video. Basically, it's me following a target moving across the screen on the horizontal. If pursuits are impaired, well, you can test it using VNG, using eye tracking device like the right eye system again. Again, compare horizontal to vertical. You can do it at bedside. And again, I would stress here, it's actually pretty valuable to know at which speed are you getting the breakdown. So you can start really slow, and then the next time you go a little faster, and then a little faster. And that's important to know therapeutically, because if there's a breakdown at a faster speed, then you might want to use, even when you do your no-no strategy to help correct it, you may want to match the speed, you know, that's impaired with your head movement. Or you could do a times zero strategy. And again, I think matching that speed can add another element of benefit here. Time zero head pursuit is like this. So your eyes and your head follow the target. I think you'd be really surprised if you do just a little bit of this. If you find that as you're assessing pursuits, you're looking for smoothness of movement in the eyes, and if you see that as the eyes move, they're kind of rough. You know, they're kind of bouncing in there. It could be really small, but you can tell it's just not smooth. Sometimes you see some pretty big saccadic intrusions in there. Maybe the eyes get pushed further ahead and come back, or maybe they get pushed off plane. They may get pushed down on the horizontal pursuit. Either way, there's a deviation off target. Okay, there's these intrusions in there. I think you'd be really surprised to see how powerful a time zero strategy is to improve that. You should see a difference pretty much right away. There's always exceptions. Vergence, convergence and divergence. Okay, I think we've heard this before. You want to test convergence insufficiency. We saw that earlier. If you hold a target close and your eye is not, one of your eyes or both eyes are not able to maintain convergence, that's insufficiency. Spasm is when they maintain convergence and there's really no reason for them to do that. We have different strategies for each of these presentations. You know, the pencil push-ups, you can use the Brock string. These are all great for your convergence insufficiency. You want to use a more of a farther strategy for convergent spasm. So you look at a target that's far away and you move your eyes to a target that's further away. And it may be further away to the right or to the left, depending on what's needed. Sorry, I can't elaborate further on that for now. But also consider that, especially with convergent spasms, it could be a vestibular issue. Especially an otolithic problem can give you the convergence spasm or gravitational problem. So you want to test for skew deviation. You want to test basically the alignment, especially on the vertical of the eyes. And to do that, you can just look up Maddox rod or cover test. Maddox rod is a great way to quickly see at bedside if there's a vertical deviation of the eye. But there's other apps, the subjective vertical app, visual vertical app. And typically what you'll find is that if there's a hyperactive otolithic system and an underactive, let's say underactive on the other side, it will create a skew and it can alter the subjective vertical. So to stimulate the frontal lobe, so let's say everything's working, but you want to know, okay, what can I do to activate and stimulate just the frontal lobe? Well, saccades are great for that. Saccades are mediated by the frontal lobe. Anti-saccades, memory-guided saccades, the fast phase of the optokinetic, especially the look OPK, is frontal, and the manual task saccades with interactive metronome, which I'm dying to show you. So if we want to do a right horizontal saccade, it would activate the left frontal lobe and the right cerebellum. And because the nucleus, the abducens nucleus for horizontal movements is in the right pons for right saccades, then the right pons would also be engaged here. The same is true for the exact opposite. Just reverse what I said. So left saccades, right frontal lobe, left cerebellum, left pons. What about vertical saccades? And that's a great frontal lobe, just bilateral frontal lobe stimulation. Bilateral frontal, bilateral cerebellum, and bilateral midbrain or mesencephalon. If you want to stimulate the parietal lobe, then you want to use your pursuits. Of course, Optokinetic system will do that too. If it's a look OPK, the slow phase or the pursuit phase of the OPK is more parietal. And from a visual field standpoint, so if you're familiar with Hemistim stimulation, a visual stimulation, in the lower field of view would stimulate the parietal lobe. So this is I'm not going to play it, but if we're to do a right pursuit, so if I'm the patient pursuing to the right, this would activate the parietal lobe on the right side and the cerebellum on the left side, as well as the pons on the right side. Same is true with the left to reverse everything. On the vertical, so if you pursue it on the vertical, bilateral parietal lobe, bilateral cerebellum, bilateral pons, bilateral mesencephalon, so pretty global effect. But what if we combine saccades and pursuits? And this is where it gets even greater. So if you combine saccades and pursuit, you can really isolate a hemisphere completely. So if I wanted to do a left brain type of eye movement strategy, this is what was used, by the way, in that study that I mentioned earlier by Dr. Carrick, which was on stroke patients. They used this strategy. There are saccades that move up into, saccades that move up into the right for a left brain or left frontal lobe effect, and pursue back down into the left. I'm sorry, saccade up into the right for the left frontal lobe, pursuit back down to the left for the left parietal lobe. But I don't know if you've noticed, but only one side of the mesencephalon is highlighted here. So this is the only way you can isolate left or right mesencephalon if you have this diagonal strategy here. Same is true for the reversed direction here for the right brain. And temporal lobe stimulation is upper field of view. So right upper field is left temporal, left upper field is right temporal. I'm sorry, I'm going to really go fast through these. On our website, thefocusbuilderapp.com, we actually have a guide for Hemistim that we've created. It's a PDF. You can just go on there and open it and download it or print it for yourself. But basically, the parietal lobe and the temporal lobe have different responses to vision. And so the parietal lobe is activated more so through low contrast, high processing speed, the blue end of the spectrum of light or color, and large stimulus and lower field of view. Temporal lobe is the exact opposite. This is an example of a left temporal strategy. This is an example of a right parietal lobe strategy. So see the blinking is a little faster. The squares are a little bit larger. The colors are different. Lower field of view. The right brain and left brain actually are kind of similar to, so the right brain is similar to the parietal criteria, and the left brain is similar to the temporal. So what you see on the right brain, again, is big picture, high frequency, blue end of the spectrum, large stimulus, low contrast. Exact opposite for the left brain. And this would be a right hemispheric strategy and a left hemispheric strategy. Cerebellum is especially involved in accuracy, but if you really want to engage the cerebellum, consider the diagonal strategies. Those are pretty powerful for that. So, lastly, I don't want to leave this out. We decided to combine saccades with a manual task and interactive metronome. We did that because there's lots of evidence out there that saccades are so effective at activating the frontal lobe, the cerebellum. Same thing with the interactive metronome. They both target similar regions. But what if we made it very specific? Well, this is an example of, I don't know, you may not be able to hear it. There's a ding with every, so there's an auditory cue with a visual cue, and what you have to do is touch the target at the same time that it beats. And if you get it on time, it lights up green. If you get it late, it lights up red. If you get it early, it lights up yellow. Okay, so it gives you feedback, and you can adjust your speed. Now, if you're doing this and you're doing a circular movement as well, so much better. It's great, you know, it's very effective with just that linear movement, but you know, complex movement we know are so awesome for the cerebellum, so do a circular movement along with it. I had a patient who I tested with the memory-guided saccades, and she struggled so bad to do these memory-guided saccades. And then I just had her do this exercise and then go back to the memory-guided saccades, and she's like, oh my gosh, it's so much easier. And she had been working at those memory-guided saccades for at least a month, and that slight little change, we do this first, made all the difference. So lastly, this is the last slide. I want to just show you this video. And you could see a before and after. This is immediately before and after. Just look at her fingers. This is a good frontal lobe test. See that hesitation there? It actually was a freeze. You get another hesitation there. And right after doing the saccadic metronome, her comment was like, wow, it feels so much smoother. Like she felt like the stiffness wasn't there. Look at the amplitude on this one. It's pretty small amplitude. He came for attention issues, ADHD, and this is after, and there's like minutes between those two. It's like right after. But you see his amplitude's improved a lot. This one, you could probably see the most dramatic change. Just look how much slower, well, look at the mirroring for one. You can see the other hand moving to help give feedback and improve the movement. But look at how slow it is. And especially as compared to her left. Her left is so much better. And now we'll see the post right after doing the saccadic metronome. It's a lot faster. I mean, if you're used to looking at these tests, you can pick it up pretty easily. There's a definite difference there. One last one, you could see here, this particular patient, and all I did was the saccadic metronome, nothing else. I mean, we could do, again, our multimodal approach and have an even better change. But just notice in this case here how she get the posterior pulsion there. So I did vertical saccadic saccades with interactive metronome on the vertical. I did the right arm first, did about 5 on the right, and all the way up 5 on the left. And you can see she's far more stable afterwards. She didn't have that posterior pulsion. No, I just use a gooseneck iPad holder that I move around the office. And I use the iPad Pro, which is the bigger one, and I have them doing on that. We can't really feed it to a touch screen TV yet. we're looking into that, but no, we don't have a solution on how to do that yet. Excuse me? Oh, it's already in the app. The app does it all. You select, it's on there. Yeah, just look. No. It's all in the app. Select. You'll see at the bottom it says metronome on or off for saccades. All saccade exercises in the app have the ability to turn on metronome or not. And if you turn it on, it'll be there automatically. Now you'll see that the first time we hit it 3 times on the first one, that's just to kind of get on beat. Those don't count towards your score because you get a score on these. It gives you feedback. You can save the scores too. But as you touch it 3 times just to get the rhythm, they're practice rings. And then you start moving with it. Okay? But the timing is always, the same. You can make it half a second. You can make it a second or 2 seconds. You can make it real slow if you want to do a really big circle. So you can play around anywhere you want. But it's all in there. You don't have to combine anything else. So that is a multimodal approach all in one. All right, thank you very much for being here and for listening to me.